In the name of Allah, the entirely merciful, the especially merciful. This slide delves into the physicochemical approach to acid-base balance, where albumin plays a starring role as a major, non-volatile weak acid, often abbreviated as a TOT. These are acids, like proteins and phosphate, that don't evaporate and are not fully dissociated at the body's pH. Now, let's quantify albumin's contribution. With a molecular mass of 66 kDa, albumin carries about 19 negative charges at a pH of 7.4. If we do the math for a typical plasma albumin of 40 grams per liter, that converts to about 0.6 millimoles per liter. Multiplying by its 19 charges thus approximately 11 milliequivalents per liter of negative charge. We can also use a standard formula, which for a pH of 7.4 simplifies to multiplying the albumin concentration by about 0.25, giving us a very similar value of 10 milliequivalent/L. When we add the negative charges from glucose and inorganic phosphate, we get a total weak ion concentration of about 16 milliequivalent/L. The crucial clinical takeaway is this: when albumin is low, this major source of negative charge is lost, creating a relative increase in other cations and contributing to a metabolic alkalosis. This is why critically patients with hypoalbuminemia often have a hidden acidosis. The low albumin masks it by making the pH look artificially normal or even alkaline. This slide gives us the powerful clinical translation of all that chemistry. We can now express albumin's impact on acid-base balance as a simple, memorable rule. For every 1 gram per deciliter change in serum albumin, we see an opposite change of approximately 2.5 milliequivalents per liter in the serum bicarbonate. Let's be explicit about the direction, because this is critical. An increase in albumin by 1 gram per deciliter is associated with a decrease in bicarbonate of 2.5 milliequivalent per liter. This lowers the pH, contributing to a metabolic acidosis. Conversely, a decrease in albumin by 1 gram per deciliter is associated with an increase in bicarbonate of 3.0 milliequivalent per liter. This raises the pH, creating a metabolic alkalosis. This is why a critically ill patient with severe hypoalbuminemia can have a surprisingly normal or even alkalotic pH, even when they are profoundly sick. The low albumin is masking an underlying metabolic acidosis. Thank you.